Hello, I'm Yael Maxwell with TCTMD. I'm in Chicago for AHA Scientific Sessions 2014, where, on top of reporting on important science, I've found several interventional cardiology fellows interested in sharing their experiences as trainees and offering opinions on issues that matter to them. This is Fellows Forum. Why did you decide to attend AHA 2014?
Well, I had the opportunity to present a complex coronary case here, and then just also the opportunity to partake in the environment, the clinical science, the basic science, all the late-breaking clinical trials and presentations. It's been great.
I also use this as a platform to connect with friends and colleagues because I think it's an important part of our careers to be able to network with a variety of people.
So describe a typical day for you here.
Well, it's been very busy. It kind of depends on my responsibilities. But for example, at this meeting, because we have a big presentation, the days start often with meetings with the research group, talking about, what the latest tweak to our presentation or slides are going to be, and then meetings with press, talk about some of the late-breaking findings, and also thinking about how to get that message out effectively.
Kind of seeing the posters. I think the posters are dear to my heart because I myself present a lot of them because it lets you kind of interact with people who are presenting preliminary findings and more novel, innovative stuff that can form ideas for your own research.
Showing up for some of the plenary sessions early and late-breaking clinical trials in the afternoon, and then throughout the day, from breakfast to lunch to in between meetings, the opportunity to see friends that I haven't seen in a long time, that I've worked with at some point from med school all the way up through interventional fellowship.
Do you think it's important for fellows to attend large meetings like this, and should it be a required part of the training curriculum?
Well, I think required is a little strong, but I must say heavily encouraged and hopefully supported by fellowship programs.
I think it should be mandatory. I think that even to write abstracts and to write papers also should be mandatory. But here's a great place to know people, to know what's happening, to know people that make things happen. So I think that should be mandatory for sure.
I do think it's extremely important for a lot of reasons. From an educational standpoint, it's extremely important. I think it's inspiring too.
As far as making things a requirement, I always feel that things should come from within rather than just having people to do something as a requirement. So I think that all of us are at a stage in our career wherein we understand the importance of science and importance of medicine and how it is practiced and kind of trying to get better at it. So I think all fellows should attend it. Requirement, I'm not so sure.
What about the training program for interventionalists? Would you like to see change over the next 5 to 10 years?
I think the training programs are in a state of flux, and this is probably the time that it's going to be in the most flux. And the reason I say that is because the last probably 5 years we have seen so much development in interventional cardiology, and most programs have moved from a traditional 1 year to at least having the ability to train people for more than 1 year, at least 2 or 3 years.
I'm now a PGY 8. Soon to be a PGY 9. That's a long time to train in medicine, cardiology, and interventional cardiology. But unfortunately, with today's duty hour restrictions and things like that, I think it's necessary, and I think it'll make us better doctors.
Why did you decide to pursue interventional cardiology as a career choice?
Tough question. I just like to play with needles and wires, I guess.
So I think it's a very exciting specialty with innovation, data, evidence, and patient care all integrated. So
both the combination of equipment and devices changed, but then also the decision-making process changed. I think inherently the training programs are going to have to try to keep up with novel teaching methods and also just novel experiences throughout the lab.
The other half of it really is the science that we can do and changing how we practice medicine. And I think that's very, very exciting in interventional cardiology, and specifically for me, structural interventional cardiology. And so, that's a big driver of why I chose the field.
What is your career plan after fellowship?
Well, my plan would be to come on to faculty at a major academic institution and focus on the use of antiplatelet and anticoagulant medications in structural heart disease.
The plan is to be doing interventional cardiology and peripheral intervention, hopefully looking to academic centers and maintaining involvement in clinical research going forward.
I'm not sure yet. I'm starting to look for jobs, and I applied for both private practice and academic jobs.
that I hope to be in a large academic center practicing patient care and research.
What is the biggest challenge facing interventional fellows today?
There's just so much to learn, and the science is evolving as quickly as we're trying to catch up with the basics that we should know. So just coming out of late-breaking clinical trials, there's so much about decision making, even just surrounding the actual intervention, that changes every hour and every day.
Managing your time. Days in the cath lab are very long. You often want to be there for as many cases as you can to gain experience and to gain proficiency in the procedures, but that doesn't leave a lot of time for research that you might be pursuing, and maybe more importantly for family life and things outside of medicine.
We are starting to embark on extremely high-risk procedures, which, if done right, they change the outcome, but if done wrong or in inexperienced hands, really can hurt patients. So I think that the biggest challenge is trying to gain mastery over as many procedures as you possibly can.
The drop in volume, I would say so. There are new procedures that have been added, like TAVRs and all the structural thing and vascular, but coronary numbers are dropping. I think general cardiologists and we are doing great jobs on preventing people to show up, but that's a challenge because as any interventional specialty, the more you do, the better you become.